Thank you very much, Craig. It's quite a pleasure to be here. I'm actually pretty excited that I can actually make it to the podium at this point in time because I did have pretty serious injury to my femur. I want to thank Thomson Rogers and Obaya for sponsoring the event and having me here. I'm a neuroradiologist and I've been involved in the imaging of brain trauma for quite some time from a clinical perspective. But I've also been sort of dragged into the concept of research in imaging for brain trauma. This is something I've been only doing for the last, I'd say, 3 or 4 years. My main interest has been, as Craig said, blood flow. And I sort of consider myself a plumber. I just want to know, how does the brain control blood flow? But now with this new demand to understand functional imaging, that really gets involved more in understanding how neurons are signaling each other. So I guess I'm becoming an electrician now. So what I would like to be able to do is try to, in the simplest way, show you what we know about imaging brain trauma from a clinical perspective, and then add to that at the end information about what we're learning using more advanced imaging technologies and research techniques. Now, my first slide is interesting because this was not supposed to show up right here, but it's there. Okay, I have no disclosures. From a statistical perspective, how significant is brain trauma and what impact does that have in terms of societal and economic issues? So first of all, traumatic brain injury. Back in 2010, the CDC did an analysis and determined that there are roughly 1.7 million traumatic brain events that occur annually, and I think this figure probably has gone up a bit since then. The age groups affected, the very young, and of course the teenage group, which is the most probably at-risk group here, and then the elderly. Now, of those groups, the elderly are at the highest risk for mortality following a brain injury. Now, from a gender perspective, we know that males tend to injure their brain more frequently than women from these traumatic events. And then the cost of traumatic brain injury is quite high. We're looking at about $76 billion, and that was back in 2000. Again, this is probably likely to be a higher figure now. And that is both, the indirect cost, loss of productivity, et cetera, et cetera. So it's an all-inclusive figure. So from an imaging or an imager, imaging perspective, or an imager like me, there are two types of brain injury. There are the concussive events and then all the rest. And concussion and all the rest of brain injury share two features. One is that there is usually a loss of consciousness, and there's a blow to the head, obviously causing the loss of consciousness. But the difference between these two entities is that the imaging is normal in concussion. So if I take you, you say you've had a blow to the head, you've lost consciousness, you have all these symptoms, I put you in the most sophisticated MR scanner in the world and I do a scan, I'll see nothing. So the challenge to us has become, what can we do in the future to try to tease out the subtle effects of the injury on the brain structure and function itself? Can we actually see these events and see changes in structure caused by that relatively mild brain injury? And we call it relatively mild, but we know it can be severely symptomatic for patients. So our goals are, first of all, to protect a person's life. So after a significant head injury, we need to do urgent imaging to determine if there is something that's immediately life-threatening that needs to be treated. Then in the more subacute and chronic phase, we want to understand how our management is affecting the patient. So we'll do repeat imaging. Is the blood going away? Is the blood collecting in the brain getting worse? And then finally, I'm going to spend time at the end of the presentation on how to make the diagnosis of concussion with imaging. Now, the two types of imaging that we use are structural and functional. Structural imaging, obviously, is as what it says. We look at the brain structure with our imaging tools and determine how disrupted the structure is. And with more advanced brain injury, this is easy to see. The functional imaging is the more research side of it, which we would like to translate into the clinic eventually to try to add to our diagnostic capability. So what is the mechanism of brain injury? Now, the brain is surrounded by cerebral spinal fluid. And just outside of that fluid is the skull itself. So if you have a blow to the head like this, the first thing that happens is the head moves and the skull moves and the brain sits there cushioned by the cerebral spinal fluid. It's not very long thereafter when the skull contacts the brain and actually directly impacts the brain and causes the injury. Now the brain, the skull, and the whole head are moving in the same direction. The problem then becomes that the head snaps back the other way. So the brain is moving this way, the head is beginning to snap back this way, and eventually the other side of the skull contacts the brain. So we would call this right here the coup injury, and this would be the contra-coup injury. And we can see that on imaging. We don't always get both types of injury in every single traumatic event. So the CAT scan turns out to be our first choice for imaging. The CAT scan is, as you see here, a very wide open sort of donut-shaped device that allows us to put patients who are attached to all kinds of tubes and lines directly into the system without difficulty. These are usually located in emergency rooms so that we can transfer patients immediately into these devices and get an immediate assessment of whether or not there may be a life-threatening injury. So, for example, we could assess for a depressed skull fracture. This black area here is air brought in through a tear in the skin, and this depression of the skull will actually impact the brain and potentially injure it. This would need surgical correction. There are other more subtle types of injury indicated by the red arrows. These are very hairline fractures that we can detect on the CT scan, and the importance here is that if they connect to these aerated sinuses, bacteria can get into the skull, inside the skull, and into the fluid around the brain and cause a meningitis. So this is something that's important to recognize as a feature of skull injury. Now, if we go further into the brain, we go to the coverings of the brain, the meninges. And what can happen there is you can get bleeding into these meninges. And this type of bleeding is called an epidural hematoma. This is arterial type of bleeding, which, because it's arterial, can accumulate very quickly. If you're in the emergency room and a person has had a brain injury and they're suddenly losing consciousness rapidly and deteriorating, this is what needs to be addressed right away. And if you're in the emergency room and a neurosurgeon happens to be there and the patient is basically losing neurological function on the spot, they'll do a burr hole, and I've seen it done on the spot, and you have to stand back because the blood comes out with such a force it can go shooting across the room. So you can understand some of the forces associated with this accumulating blood and the impact it can have on compressing the brain tissue. So this is kind of an indirect injury to the brain. It's bleeding that's pressing on the brain and potentially injuring it. Then we have this type of hematoma. This is a subdural hematoma. White on CT usually means blood, unless a contrast agent has been given. So this white collection indicated by the arrows here is bleeding, again, into the coverings of the brain. And this is a more insidious type of bleeding. This bleeding is caused by venous bleeding. So it's slower. It's not under as much pressure, but it can accumulate over time, and you may become complacent. You might get a CT like this, and the patient's fine, and you see the blood there, and you say, well, we don't really have to act on this urgently. But if left unobserved, this patient the hematoma can continue to accumulate and accumulate and accumulate, and eventually produce as much mass effect as that epidural hematoma I showed you before, and can be just as life-threatening. So this would then need urgent surgical intervention. Now, we can do MRI studies in patients like this. Now, MRI, why would we use an MRI in an acute setting? Well, we usually don't. What MRI offers on top of CT is that it shows more subtle forms of injury that are harder to see on the CAT scan. Basically, the CAT scan allows us to see all of the life-threatening conditions quickly and very clearly. So it is the imaging method of choice for traumatic brain injury. The MRI, on the other hand, as I was saying, can reveal more subtle injury and is much more effective at revealing the overall extent of the brain injury. So it shows things that CT can't show. So here we see, as we go deeper in our sort of range of injuries to the head, direct injury to the brain. This is called a contusion. We lose the gray-white differentiation. The gray matter versus the white matter that you see back here is gone because there's all this swelling and edema and fluid in the brain. And we see these bright areas, which again, bright on the CT scan indicates hemorrhage. So there are a number of hemorrhages right in the brain tissue itself. This is direct trauma to the brain injury, and this type of trauma, brain does not recover very well from. And we can see on the MR, same thing, but we see a lot of additional injury that the CT is not revealing. Now, the end result of that contusion is what we see here. We see this black area, which is replacement of brain by fluid. So the brain tissue is gone. It's replaced by fluid now. And then we see this white stuff. That is what we call gliosis. This is the inflammatory reaction to the damaged brain. The glial cells, gliosis, come in and basically take all of the dead tissue out of there. And what you're left behind with is this glial cell array. And there are virtually no neurons in that white area. So the brain is not functioning. So we can see this whole part of this patient's brain would not be working. Okay, so now I'm going to go into more subtle forms of injury. And to describe that, I want to go into a little bit of the anatomy of a neuron and what it's doing and what it looks like. So what we can see here is a cell body, and we see these little arms coming off the cell body. These are the little arms that receive signals from other neurons. And when this neuron decides it's time to decide that these signals that I'm getting are important, it will then fire a signal down this long axon and communicates with other neurons. And this long structure is fragile. It's very small. I'm going to get into how delicate these things are. But you've basically got some of these that start in your brain way up here and go all the way down into your spinal cord, and they're much smaller than the size of a human hair. That's a long way to go for a very tiny, delicate structure. And this is what they actually look like in a brain where all of the fatty tissue has been removed, leaving the cells behind. And you can see here, all of these neuronal cell bodies are lined up, and the dendrites are all connected to each other. This would be the gray matter in here, and they're all kind of buzzing around, talking to each other, trying to decide what to do. And finally, some make a decision, and they send a signal down these axons to communicate to another part of the brain. Now, the blood vessels are equally as complex. So if you take all the tissue out of the brain and just leave behind the blood vessels, you can see it almost looks like there's no room for brain. And that's really true because we don't really separate the neurons from the blood vessels anymore. We call it a neurovascular unit now. And the blood vessels and the nerves are in direct connection and communication with each other. If a neuron starts to become active here, the blood vessels in the region immediately start supplying it with blood flow. Because these are like little Ferraris up here. They're operating almost at the limit of biology, what biology can do, at the limit. So when they turn on, they need blood. And this is what I study. I really enjoy looking at this and trying to figure out what the relationship is between these structures. So what happens when you have a more subtle form of brain injury? We have the gray matter here. We have the white matter here. The gray matter are where the cell bodies are. The white matter is where these long filaments extend to other parts of the brain and the spinal cord. And as you know, there's at any interface between substances of different densities, because we do have a different density between the gray matter and the white matter is filled with these axons and tends to be stiffer. So you can imagine when you hit your head, the gray matter is going to slide across the white matter. It's called shearing injury. And what we see there is that the interface between gray matter and white matter is this destruction or disruption of these axons. Now some of this, and this is usually a fatal event to the neurons. They don't recover from this. They'll stop working. However, you can get even more subtle injury where the axons aren't really fully disrupted. So this becomes, can you imagine how hard it must be to see an axon that's just slightly injured? It's smaller than the size of a human hair, and you're asking me, the neuroradiologist, to pick it up. It's quite a challenge. What does this diffuse axonal injury look like? So this is DAI. You've probably heard it. You may have heard about that before. Diffuse axonal injury is shown up as white spots at the interface between the gray and the white matter. Some of them can be deeper, depending on where these axons are sheared off. So we look for these white spots. When I get an MRI from somebody who's had brain trauma, I look for these things. The problem with the white spots is they're not specific, okay? Anyone who's 50 years or older in the audience has probably collected a few of these things, just as a natural aging phenomenon. It becomes accelerated if you smoke, if you have high blood pressure, if you have high cholesterol levels, if you're inactive. They tend to accumulate. We call it microangiopathic disease because my favorite little blood vessels get plugged up. And they cause little white spots. Now, if you're 20, you should never have any of these. So if I see somebody who's had brain trauma and they're 20 years old, and they have these things, I'd say, this is pretty good evidence to me that you've hit your head. Now, even better evidence, I'm going to show you next, on this iron-sensitive sequence. I showed you one before, it was normal. This iron-sensitive sequence is not normal. Now, this flare sequence, which shows us the white spots, is normal in this patient, but we see these black spots on the iron-sensitive sequence. No imaging study for trauma using MRI is complete without this iron-sensitive sequence. You must have it because it is showing exactly where there has been bleeding in the brain. And a normal brain should have no blood in it, unless you have a history of high blood pressure, a bleeding disorder, you're on an anticoagulant, or you've hit your head. So when I see something like this, I need to know, okay, does this patient have any of these other disorders? And if they don't, and I see these, it's diagnostic for me for head trauma. Okay, so if I see a patient who has this, I don't have any questions. This is virtually completely 100% diagnostic of a brain injury. And furthermore, it's the distribution of this tissue loss here that's very important as well. We tend to see it in the front of the brain, in the anterior frontal lobes, and in the anterior temporal lobes. So I'm going to talk about the more subtle form of brain injury, concussion. And you can see from the symptoms of concussion, memory impairment, confusion, drowsiness, dizziness, visual problems, headache, photophobia. It's very easy for me to say to you that I have these things, but how can you confirm that I have them? There's no easy way to do that. We turn to neurology, or we turn to neuropsychology to answer these questions for us. And there has been progress made with this type of testing. But the bad news, it's still imperfect in single subjects. So I pulled a paper recently, it's not that recent, 2006, from a journal called Assessment. It's a neuropsychology publication. And they were using a California verbal learning test, and it's a battery of tests to try to determine if a person was truly malingering or not, reporting these symptoms truthfully. And it turns out that even with this battery of tests, the sensitivity was only 50%. What does that mean? The sensitivity is if I take 10 people and I have 5 who are known to have had a concussion and are reporting their symptoms, that I will be able to detect the ones with concussion 100% of the time. But you can see here, the accuracy of this test is only 50%. The sensitivity is 95%, meaning if the test is positive, I'm 95% sure you have it, but I only have a 50-50 chance of actually detecting the people who are truly reporting the symptoms versus not. So the test would miss 50% of malingerers. So that's about as good as neuropsychology can do. So the question is, can advanced imaging do any better than that? Okay, well, the brain is very delicate, as I mentioned. This is a neuron that was grown on a computer chip. So you can see the connections in the computer chip connecting the transistors together. This is the neuron sending out all of these little delicate delicate little fibers for which to communicate with other neurons. So you can see we have, and these fibers are biological fibers. They're not metallic. They're not made of sand, basically. They're made of gentle, delicate materials, biological membranes and materials. So we have about 100 billion of these in our brain. In the most advanced computer chips today, there are about 5 to 10 billion transistors. So we have about 100 billion neurons in our brain with about 100 trillion connections called synapses. The diameter of these is about 1 micron, which means you could put 100 of these across a human hair, and within a human hair, there would be hundreds to maybe 1,000 axons in a human hair. And if you added up the length of all of these things in the brain, it would go from here to halfway to the moon. So we have a tremendous amount of wiring in our brain, a huge amount of wiring in our brain. How do we disentangle this wiring? Well, this is a pretty famous researcher, Van Wedeen, who works at the Massachusetts General Hospital. I initially trained there. And he developed an advanced MRI system using this thing. And this is a head insert. This is a gradient head insert, which allows us to use very strong magnetic fields, 10 times stronger than what we use clinically. And these magnetic fields, which switch quickly, allow us to increase the spatial resolution, get finer and finer and finer, kind of microscopic images of the brain. So how well did he perform? And by the way, when he turned this on for the very first time in Charleston, the energy required to drive the amplifiers was so great that they had a blackout temporarily when he started imaging a brain. So they fixed that problem since then, he's generated phenomenal images of this wiring. And this is what one of them looks like. So you can see the density and the complexity of the wiring. Here are some other images showing big fiber tracts going back and forth through the brain. And what was groundbreaking, and which no one ever knew before, not even the neuropathologists, was this. The brain's constructed like a plaid shirt. The fibers are all interwoven with each other at 90-degree angles. This is the highest packing density that you can achieve mathematically of crossing fibers in the brain. So nature did it by itself. Okay, well that's complex, and this challenges us from an MRI perspective, and we don't have these 10-time powerful gradients, because if we did, I don't know how much of Toronto would black out every 5 minutes. We can't use this technology yet in human beings. But then there's the substructure of the neuron, and the substructure of the neuron you can see here has these fibers in it, even inside the neuron. And these fibers are critical to the health of the neuron. These are called microtubules. And the microtubules are what transport important structures from one end of the neuron all the way to the other. So macromolecules, mitochondria, cell organelles. It's critical to the life of the neuron. What's interesting is you've probably heard of chronic traumatic encephalopathy. This is what the football players are developing after multiple concussions. And they deposit a protein called tau. Well, guess what the microtubules are made of? Tau. There's tubulin and there's tau. And tau is the fastener protein that holds the tubules together. So you can imagine if you suddenly bump this thing, it's going to shake some of these tau proteins off. And guess what happens? These tau proteins tend to aggregate with each other. And when they do, they become insoluble. When they become insoluble, there are no enzyme systems in the body to get rid of them. The body biology works in aqueous media. If the solute is gone, if the proteins are no longer in the fluid, the body can't get rid of them, so they accumulate. So it makes sense what's going on with CTE. So axoplasmic transport I mentioned. So the more subtle type of injury to the axon itself is indicated here. Here we have our healthy axon. Here we have a tension or a twisting or a compressive force, and it causes damage. And the axons actually start to swell up. And it's because all this material, which is trying to go back and forth through the axon, starts to build up, and you get these little bags of sort of accumulated debris in water. This axon is not going to work well. It's still intact. And it may recover, although we don't know the natural history of this very well, it may recover. But imagine trying to image this, something that is a micron in size. Very difficult. So that's our challenge. How have we decided to attack it? Well, we have these things in our armamentarium. Diffusion tensor imaging or diffusion kurtosis imaging. There's a new thing on the block called diffusion spectrum imaging. This is using stronger gradients, just like Van Wadine was using, and being able to sense the motion of water in different directions. We have fMRI, functional MRI. If I go into the magnet and I tap my fingers and I rest, and I tap my fingers and I rest, and I analyze the images, I can see what group of neurons are being used to make that movement. There's resting state fMRI. When you're just sitting there and your brain is idling, the neurons are fluctuating. And we can see which groups of neurons are fluctuating with each other, and we can create what's called a resting state map, and I'm going to show you an example of that. This is what I do, cerebrovascular reactivity imaging. I challenge the blood vessels and say, okay, you're supposed to be able to open up to give almost doubling the blood flow to a neuron. Are you able to do that? And I have a test which allows me to assess how well the microcirculation can supply that added demand that the neurons want, because like I said, they're little Ferraris. They're gobbling up energy like crazy. They need the blood flow to support that metabolism. And then there's PET, positron emission tomography. This is a tracer technique. You give radioactive tracers that are labeled, and these radioactive tracers seek out targets like tau protein. And we now are just beginning to work with a tau protein tracer that might allow us to determine how much tau buildup there might be in a brain that's had concussions. So water diffusion is important. I mentioned diffusion imaging. How does it work? Well, I can image celery, and this is what celery looks like, and you go, well, that's pretty boring. And we know that celery has channels in it that go up and down the length of the stalk, so the water tends to go up and down the stalk, not across it, right? So I can use diffusion sensitizing gradients that are only sensitive to that direction. And what do I see? Completely different image. So now I can image the fibers in the celery. So now the brain is kind of like celery, lots of fibers. Let's see what we can do with that. And I've already shown you images of that. I showed you what Van Wadine was able to achieve with that. How can we use it clinically? Well, here's a boxer. And we see a normal subject, and we see the fibers in a normal subject. And this is before Van Wadine, so the images aren't quite as pretty. But we can see lots of fibers in the front, in the back, and the upper part of the brain. In the front of this boxer's brain, we see fewer fibers than we see here. In the back of this boxer's brain, particularly in this area in here, we see fewer fibers than what we saw in the control subject. So this brain has been hit many, 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 many times. Maybe not always concussions. Maybe a new idea or concept that's been coming out is subconcussion, where you don't lose consciousness, but you still injure the brain. So after the accumulation of all of these subconcussions, I think we're beginning to see a loss of fibers in this boxer's brain. Now, for one concussion, can we see that? That's our challenge. We have something called functional connectivity. We look at the waveform in the resting brain here. If I just do a whole slew of MR images really fast every second or so and just look at the waveform, we can compare that across the rest of the brain. So if I can say, well, does this waveform compare with the one we get from here to the one we get from here? And we find out that, well, this one compares more favorably with this one. So these two are kind of connected. So we can create a connectivity map. And the red and orange areas are where the brain is most highly connected. So these are the parts of the brain that have the highest connection to other parts of the brain. And this is called, in this case, the default mode network. Everyone in this room will have a default mode network that looks like this, in the middle part of the back brain here and to the sides. And this is the part of the brain that starts to disappear with Alzheimer's disease. We start to lose the default mode network. So we think the connectivity in Alzheimer's brain starts to drop. If we look at what this looks like before concussion and then after concussion, now these are groups of individuals. I'm not showing you a single brain here anymore. This is the problem. The signal is so small that we have to group people together, group controlled data, group patients together, and then compare them. And when we group together, we can see that there's less connectivity in the concussed brain. We can do functional MRI, and we can challenge the brain. Tap your fingers, speak a sentence, and let's see how that activates the brain. And we can see here that after concussion, there's more activity in the brain. What does that mean? Why is it more activity? Wouldn't you expect less? There's more activity because the brain is trying to push the information. It's not getting there because the connections aren't present. It's trying. So if we add this with the connectivity, we find the brain is working harder, but the signals aren't being transmitted. So this is a cutting edge. This is where we sort of are with this right now. 2 slides. So in terms of the diagnosis in concussion, we can make the diagnosis of concussion in groups of individuals, in a whole group. Put 20 people together in a group, I can make that diagnosis. But if I take one concussed person from that group and say, is that brain injured or not? There is no imaging tool I currently have that can do that. And that's what we're currently working on. It's the holy grail. Higher resolution and more sensitive functional imaging to reach that holy grail. So initially I was optimistic about the future. But then Yogi Berra came around and said the future ain't what it used to be. And I began to think he was right. But now we have a 7 Tesla MR coming to Toronto Western Hospital, which is the Slate family kindly donated a large sum to help put this in. We can see smaller structure in the brain than we've ever seen before. So in summary, we use imaging to rapidly assess patients who've had brain trauma. And we do that because we want to make sure that there are life-threatening injuries that we can detect and treat urgently. We assess their response to treatment with these images. And finally, I hope that with future work, and there's a lot of money being dumped into this right now and a lot of research being done, that we will eventually reach the holy grail of making a diagnosis of concussion in a single subject. Thank you very much for your attention.